Hello, everyone. This is Daniel Guest with Becker's Healthcare. Thank you for joining us for today's webinar, Humanizing Hospital Security with Visitor Management, Tackling Workplace Violence and Turnover Together. Before we begin, I'll walk us through a few quick housekeeping instructions. First, we'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is also being recorded and will be available after the event. You can use the same link used to log into today's webinar to access the recording. Lastly, if at any time you have issues with audio or visuals, try refreshing your browser. You can also submit any technical questions you have into the Q&A box. We are here to help. With that, I'm pleased to introduce today's speakers. We are joined by Don Campbell, Vice President of Product Management Workforce at HID Global. We also have Brent Getty, Director American Sales, Workforce HID Global. So thank you, Don and Brent, for being here today. And I'll turn the floor over to you to get us started.
Daniel, thanks for having us. We're excited to be here and presenting today. We've got a short and sweet agenda for you guys today. We're going to spend some time looking at workplace violence, more specifically how it relates to humanizing the hospital security and keeping your staff around and retention. We're going to break down some challenges that we've seen with visitor management and the visitors specifically. We'll take you through a walkthrough of many of the hospitals that we've been through, offer some strategic takeaways, and then we'll spend the last few minutes answering any questions that you may have. Before we leap into workplace violence and staff retention, we're going to talk a little bit about visitor management. So stick with us. The goals behind this are understanding what workplace violence is and creating some good staff retention policies. Hopefully, we'll give you a little different take on this topic, as it's something I know has been talked about quite a bit over the years. With that, I'll turn it over to you, Don.
Yeah, thanks, Brent. And I think as we dive into these topics and we're looking at things like workforce violence, first I want to think wait a second, how does this relate back to visitor management? But if we start at sort of the core of visitor management, what we're thinking about is, for staff in the hospital, when they see somebody else in the hospital that they don't recognize, which is all the time, right? Patients and visitors, these patients, giving them the confidence that they know that that person has been invited in, has a purpose for being here, that they're in the right place, and that this isn't some sort of incident, that they have confidence in the people around them, have been through the right process and the right visitor system. And that this is sort of the core as we start to go through this. And think about sort of the intersection of visitor and workforce violence. It is about creating a control point and a confidence point in the people that you have to allow in. If we pivot and think then about workforce violence itself, we really want to look and get takes from various people who get involved in this, and who do we pull in, who do we talk to as we go through this. And I think a lot of that as a starting place is that we want to go to sort of the numbers and start to look first at what does workforce violence cost to us when it occurs in our environment. So it's not just about who's in the space, but around what does it cost. Some of the studies, and this one in fact comes from the American Hospital Association, and what they looked at was the cost of prevention programs, increasing prevention, being proactive and trying to reduce violence and increase safety for our employees and our patients and our visitors and the whole community, versus the cost of post-event and what happens afterwards. And if you look at the various approaches from training, better security staffing, we see a lot of people these days who are incorporating weapons detection as part of a visitor process and the screening process. All of these pieces together end up having about a quarter of the cost of post-event cost from the cost to people who are hurt or staffing or equipment and replacements. And I think one of the larger things, a lot of those things have really big impact, but even onto our reputation and kind of the overall safety of the hospital, the way it's viewed in the community, the way our staff and our patients and everyone looks at us as an organization. And so we're looking at something where often if we can take the longer view, the pre-event becomes the place that we want to focus. We really want to focus on that left side and do everything we can to delay or prevent the input or hitting the costs from the post-event. And so if we look at that, what does that give for us? Like when we think about this from a budgeting perspective or a program perspective, chasing the pre-event lets us create a program that has predictable and controllable costs. And even if those costs are more than we're spending today, it still is something that's far easier than having these unpredictable, unexpected costs. We don't know if we're going to have an event or when we're going to have an event. We just know that the more we can do to prevent that from occurring, the better off we're going to be.
Hey, Don, let me jump in here and ask a maybe slightly cheeky question. If I'm in a relatively safe area, why would I invest in these pre-event costs? I mean, if I'm not going to have an incident every, let's say, roughly 4 years, why not? Why would I want to?
Yeah, I guess for a couple of reasons. One approach to security and to risk prevention is insurance, right? We could just buy more insurance. I think what I got out of the studies is primarily that is a pretty risky approach. Sure, you can buy insurance, but that's only going to help with some of those things. Insurance might help the hard costs out of a violence incident, but it's definitely not going to improve the soft costs. I mean, it's not going to make your staff feel safer. It's not going to make the community trust you. It's not going to help your reputation. So it's only a partial solution, if you ask me. And ultimately, it looks to me like bad math. It looks like the prevention side is really where we want to go.
I appreciate that, and thank you for teeing me up on really what we're talking about next. I think workplace violence and the effect that it may have on staff turnover. And when we talk about staff, I'm not just speaking about your clinical staff, but you really got to think about the non-clinical staff too. Why do they want to change employers? What makes them change careers? Why do they leave healthcare? We're seeing this across the nation. This is not an isolated incident or certain regions, and we see a lot of this, especially after this time of year. People are burned out from holidays or whatever season it is, or sometimes off hours. And I think the overwhelming and overarching theory that we're seeing is stress. And we all understand how stressful it is to work in healthcare. It's a stressful profession by nature. But when you add workplace violence in and you have to worry about what it happens and what happens when you show up at work that day, it makes it worse. And I think there's a real cost to this. So when I look at this, I was kind of amazed. So we look at staff retention costs and all of the things that you're probably doing as an organization to make sure that you keep your people around, whether that's some wellness programs or EAP, maybe tuition reimbursement, or you have, daycare or something on site. All of these things cost an organization. They cost your hospital money. And we figured if an average 200-bed hospital had roughly 1,000 employees and they spent a mere $2,000 per employee, you're spending $2 million a year. We think those estimates are very conservative, to be fair. And what I was most amazed by when I started working and specializing in healthcare was the cost of what it truly costs when a nurse leaves your organization. Found the average from the American Hospital Association is over $60,000 every time a nurse turns over. So 1% change in the average size hospital is a $300,000 annual improvement for the organization, not to mention the roughly 100 days it takes to find a new RN. And that's not even getting an RN that's going to get up to speed. While they may be technically qualified to do their job, they're not familiar with your hospital policies, procedures, organizations. There's always going to be a learning curve. And to that, it's going to directly impact the patient care and the quality of care that your customers and your community ultimately receive. I think these states, we can't overstate the impact of what staff turnover can do. And by not taking any action, you create a very challenging scenario. Don, you have anything you want to add on that, or?
I think this sort of leads into our next topic is this turnover, the costs that are associated, and the workforce violence piece. Honestly, they both come together around stress. Stress tends to be the thing that comes out of this that is one of the points that we can focus on?
Yeah, I think to your point, to really bring this home, much like we did with your slide when I was looking at this, an ounce of prevention is worth a pound of cure, something I always heard growing up. And I think looking to reach out and help your organization, your employees feel safe at work, give you a predictable cost. I think they're really necessary for growth. You can't churn through talent forever and ever. The supply is not unlimited. So I agree. Let's help reduce stress any way we can in the healthcare setting. And really, I'd like to spend a little bit of time talking about the hidden impact of that stress today. Ultimately, I think that's where we're at. And so, Don, if you'd humor me, why don't we break down some of the things that you and I've seen over the years working together? You mind playing the part of a visitor, and maybe we'll walk through what this could look like?
Yeah, no, not at all. So one of the things when I think about visitors coming to an environment, I always have to remind people and remind myself that the visitor represents somebody who's new. And while we do have recurring visitors and people are coming back for regular care, for a lot of people, their visit to the hospital today is their first time, and so they've been uncertain both from what's going on. To where do I park, to what happens when I'm walking in the door. I mean, if we're lucky, they're in kind of a lower stress situation already, but we're adding to that if we don't make these things easy and obvious for somebody. And unlike the rest of us, they don't really understand the environment, um, and have this intuition about where to go. So that unfamiliarity makes them uncertain. The more they hesitate, the more they get held back, the more they're not with the patient that they're there to visit, or they're feeling like they're going to be late, or they're going to miss the meeting, or they be in the wrong place. The more stress they get, and this can lead to very tense situations. And so I think the first thing you have to focus on there is this can be brand new to people. This needs to be really simple and really obvious.
Yeah, I agree. And I think, I'll approach this from a staff standpoint. The staff, if they have something that they're trying to help a visitor with, they don't know what that visitor may or may not need help with, and they may struggle with their own processes and tools. This is something that may feel invisible to them because they're there every day, so they don't look at it. They're maybe very focused on their area, uh, or as a staff finds a visitor that is maybe underprepared for their visit, and they don't know who they are. They're maybe a little concerned about who they're dealing with. If somebody is annoyed or stressed and kind of pacing about, it could give you potentially some anxiety, which is going to add additional staff on additional stress, excuse me, on your staff. We need to create systems that are designed to support not only the visitors, but the hospital staff and everybody that is inside the doors of that hospital. And I think ultimately that's what we should solve for today are these things. How do we thread that needle? We're looking as we're working with hospitals on how to make an unfamiliar environment at least feel a little bit more familiar, make that uncertainty go away because the documentation and maybe um, the rules and sage and ultimately lower the stress. And that's what we're here for today. Don, you want to take a walk through one of these virtual hospitals that we've been to so many of over the years?
Yeah, absolutely. And this is something like I really recommend that anytime you're working through any of these types of processes, whether we're focused on the workforce violence, staff turnover, or just looking at a typical visitor management system, the core of this is understanding what are the problems that people are facing. And from my perspective, there's no better way to do this than do it in the environment itself. Walk through the hospital, go talk to and see people in their environment, where they're working, where those problems exist, and make sure you get a good view from a lot of different perspectives. Each of these things lead to what are the core problems that people are facing, what are problems that can be feeding into the core problem that it turns out often you have to go outside of the normal box if you're really going to come up with a clean solution and actually start to address these core underlying issues versus just go and plug in a system that may or may not actually be responding to the problems that people are having. And so, yeah, let's talk it through. Personally, I'd like to start in the lobby, so maybe we could talk about that.
Yeah, so we walked in. We walked in and let's talk about it. What do you see, Don?
Okay. So the first thing is I'd like to try to get as many of the stakeholders into the lobby as possible. And it's a good place. I mean, they all come through here. They can sort of see this as sort of a core place for visitor management, a core place for control of who's coming in, a core place to start this process, though it is just the beginning. And so, involve as many people as you can, get them to give their views on what the issues are, but also look at the place, look at how it's arranged. Um, I've been in some circumstances where say we take two different hospitals. Both had very open atrium style entrances, really both very beautiful, very, very welcoming kinds of places. But one of them worked really well from a control point for visitors and for controlling who was there, and the other one didn't. The first was wide open. It wasn't really obvious when you went in where you're supposed to go. They did have signage up that says, visitors check in here, but lots of people just walk past that. Either they're, busy looking at their phones or not even noticing the sign, or they see where they're trying to go, and it's just right around the corner. They've been there before. But it was really easy and obvious to see people just going every direction. The other, just as nice a lobby, but as you came in, they had some mats lined up, across the lobby that aimed right at the visitor check-in. And as you got there, there was a short rope line that defined the space even more. And literally everyone walked in, immediately followed this path right up to, the security team that was checking people in there, and walked straight up, started to, identify themselves, and began the process. A few people came in that knew they weren't ready to go in. They would step aside into sort of the seating area. They had another open area for making calls, also easily accessible. People who knew what they wanted to do would spread out, but the really obvious signal just lines you up and puts you right into the starting point. So we look at things like that where there are options, to between two different places of what's working, what's not, and just take those ideas from the places that have got that piece solved. That second site didn't have everything solved. They borrowed a couple of ideas from the first one as they went on as well.
I can see that. Let's take a little walk down our virtual hospital and spend some time where I unfortunately have had to spend more time for recently than I like. That probably comes with being an old guy who still tries to play hockey. Radiology. I think about the radiology department at a hospital that I go to. My favorite thing about it as a patient is there's a side parking lot that nobody, well, before this podcast knows about. I can walk right in the side door. Nobody bothers me. I can get an X-ray or MRI or whatever it is that I need to do and sneak right back out. And that's fine. It's a really wonderful experience for me as a patient, but for me as an access control professional and somebody who works in healthcare, it gets a little concerning when I don't have to check in. And if I have a secondary appointment, I head down the hallway. Maybe I go see somebody else and nobody knows that I'm there. It's a really interesting, kind of use case. And it's something that for what we do, Don, I think this is probably somewhere that we should maybe look to put a kiosk.
Yeah, I think so. And it seems like first off, I want to find out where you go because that seems super convenient. And I spend more of my time in imagery than I'd like to admit. So yeah, that seems like a great convenience for people. And how do we then um, bring them in as part of the solution and help them with that? It sounds like they're fairly accommodating to their patients. They'd probably be willing to support what we're trying to do for visitor management as well. So definitely something to ask them about.
Yeah, I think, we've actually started some conversations with them, and I think the conversation is, this parking lot doesn't have to shut down. You can still use it. There are ways to embrace these cool little nooks and crannies of your hospital and keep the rest of your staff safe. And, for this use case, it's very clearly a kiosk and training that staff to help get them checked in. But, I think it's a small use case with this in particular, but it's one that I like to call out because as one of our coworkers, Eric, often says, if you've seen one hospital, you've seen one hospital. You guys do so many
Yeah.
things. That you do the same thing, but you do it differently at every place. And it's one of the really cool things that I like about our job is being able to walk these hospitals. I was able to walk one today and create a unique problem or understand their unique problem, I guess, and solve it because of some of the wonderful things we'd seen at other hospitals. But let's before I derail us too much, let's keep taking our tour, and I'll let you talk about this next one. And hopefully, it's somewhere that you haven't spent a lot of time of recently, or ever, for that matter.
Yeah, I do try to stay out of the emergency room these days. Not as much fun when I was playing more sports and going in for the fun reasons. I mean, not fun at the time at that point, but um, probably one of the biggest challenges that I see at every hospital tends to be around the emergency room. They tend to be at first, a lot have like two entrances, so you might have the ambulance entrance and the walk-in entrance, two different, completely different problems you have to solve that can be very difficult to sort and figure out. Secondly, they tend to be at a different pace. They tend to lack for enough space in a lot of places, a lot of times. And so, where do things go? How does it tie together? Um, I think part of it is look at them at different times. Talk to the staff every single place you go. What are the things they struggle with? I've seen a few people approach this where the emergency room is almost treated like it's the outside, and coming out of the emergency room is where you become a visitor, and they start to put a badge on you and bring you in. So more of the emergency room has a different set of controls, and you go into visitor controls or patient controls only as you come out. I've seen some that go with hybrid. They're starting to tie this into some of them with biometrics and weapon detection, where they route a subset of people in through the visitor check-in portion, and others get captured later. So look for different solutions. Again, if you have the space, kiosks can work really well. Um, if you don't, how do you tie it into the space and processes that you have? And honestly, one of the ones I think does work well in the really high stress situations is the visitor process starts when they come out of the emergency room and go into the rest of the hospital. Again, depends on your hospital and the layout. Can you actually control it that way? And in a lot of the places I've been, it's a pretty good approach.
And I think a lot of it depends ultimately on when your hospital is built and just really the layout. But that's one of the things that you and I've gotten to do a lot of over the years is as we're touring hospitals, we've got developed an eye for it. It's been a lot of fun to see. And we'll keep our tour going out of the emergency room. I have aging parents, and unfortunately, they brought me to the ICU more times than I care to admit over the years, and taking care of them. And it's the ICU is a really interesting place in the hospital. It is, somebody who is, needs a plethora of extra attention, obviously, intensive care. But it's somewhere that you really have to be diligent on the access. Can you have who can be in that room? I remember when we were visiting my dad recently that they wouldn't let my daughter back because she wasn't old enough. And there were times that my sister and my mom were already there, and I couldn't go back because they only allowed two patients in the room at any given time to make sure that they had enough space to work. And I think looking at the limitations that you have on the visitor piece within the ICU is some really interesting use cases because at the hospital that we were at for this time, they had to pick up the phone every time somebody got there and call the nurse. And she may or may not, or they may or may not have been busy. They had to answer the phone and stop what they were doing to say, oh, yeah, you can have another person in room 5, or no, you can't. My perhaps favorite ICU story is not visitor management related, Don, and I don't want to steal your thunder because I know it's yours. But if I recall, you shared a story with me a couple of years ago about a charge nurse who was working on a different floor or something in the ICU. And did she threaten to take the door off the hinges because she couldn't get into the pharmacy? What was it?
Yeah, she was staffed up to ICU and working, and she couldn't get into into the pharmacy. She couldn't pick up drugs for the patients. Actually, she didn't threaten. Her bosses did. The senior staff there, as we were doing this walkthrough, caught the security was with us, and whole aside on if they can't fix this issue, he's taking the door off the hinges because it's slowing them down. It's harming patient care. And honestly, if we're going through a walkthrough like this, we are going to see things like this. We're going to see things that are blocking them from what issues and problems they have. Fortunately, with security with us, they were able to set up a time to come talk about it and figure out a better process and calm them down, get them back into the right mindset for our our tour and for us to go through and look at workplace violence and how that related with the systems we were talking about. And we did get some good input from them as we went forward. And sometimes we have to solve that first problem before we can get them, into the right mindset to share anything more. And we did have to wait for a second visit, a second day. We did have to come back. Once we made some progress on that core issue that they were upset about, and that's normal. That's us making progress on these. So,
And I mean, you and I have spent many hospital tours over the years. I had one this morning here in Texas, and it's something that I really enjoy about my job. I know you do too. We talked a lot about some of the not fun places in the hospital. Do you want to talk about a fun place?
yeah, I think this is. I know where we're going. This is one of my favorite experiences at a hospital. I actually started outside the hospital in the parking lot, and there is this guy wearing this giant visitor badge that was about 2 or 3 times the size of normal. That said, hi, I'm visiting my child at in the hospital name. And he was smiling and shaking every hand in the parking lot. And I was able to figure out pretty quickly where I thought his child might be in the hospital, and how old and everything else. And this guy's taken a visitor badge that he's probably going to take home and keep as a souvenir. And you don't see that real often in these types of situations. And it turns out, as we were walking through and talked with them, they have 2 types of badges. They have the big giant one that kind of announces everything, and they had a normal one in the exact same color that was a lot smaller. Interesting that they didn't share any PII. They didn't share anything about where the hospital was, and they gave their visitors, their families, their choice about which thing they wanted to go with. And as we were doing the tour, you saw a mix of both. You saw somewhere where one person in the family is wearing the big badge and everybody else has got something small or whatever. And I just thought that was such a unique approach to how do we make this system of knowing who's there, knowing that they're authorized, knowing that they belong in this space, also something that's kind of fun and exciting for some of the people going through. And that talk about sort of changing the tension. That guy was kind of lifting everybody's spirits as he went through the parking lot. And their approach to the labor and delivery and the badges that they picked out there was it. So that's one that I learned from the hospital. I wish that had been my idea. I'd be bragging about it all the time. It's super successful, and you could just see kind of how that impacted people in small ways. But that's what we're talking about. When we're talking about lowering stress, we're talking about making this easier. It really is paying attention to all of these tensions, all of these places where it's difficult. I mean, the difference putting mats on the floor in that second lobby versus the one that just tried to use signage made all the difference in the world to people understanding where they needed to be and where they needed to go. And I think that's kind of bringing us back to what we're trying to get across here, that when we think about these types of really serious problems, and we think about something that a lot of people think of as unrelated, like visitor management, that you have to take this much wider, sort of strategic approach to thinking about how can it really impact everything, or we won't impact everything, but a much wider breadth of impact within your hospital than just plugging a system in.
Yeah, I think that was something that was really surprising when I joined HID was seeing just how holistic of a view we can take in approaching this problem. It's been really fun to solve these problems at such a macro level, and then being able to drill down and look at these use cases like this. I love that story about the green badge. It's one that I think it is a great idea. I wish you would have thought of it too. We'd have
It's all right. I've stolen it, so that's just as good.
yeah,
I mean,
just it's right there.
borrowed to be fair.
Yeah, strategically borrowed.
Yeah.
Speaking of strategic, let's take a look on how we might approach visitor management a little bit differently. I'd like to talk a little bit about workplace violence and really how interconnected it is with your staff turnover, some of the challenges that we see in hospitals, and maybe we have a couple, takeaways that we offer at the end of this. Maybe I'll, offer your cell number so they can call you whenever they have a question and want to schedule a walkthrough.
Or maybe we give them yours.
Maybe.
Yeah. Okay. How about I lead this off because
Yeah,
I
okay.
think this is my wheelhouse. The first thing that I really look at is I think about sort of the first step of the visitor system and lowering stress is remember the mindset that they're in. Remember that they're unfamiliar with the space. Assume it's their first time here and they've never been here before. And so, how do we pick every single opportunity to make it easy from the information we send them while they're still at home to arrival near the campus, parking, coming through the door? Don't just think about software sitting behind a desk or how you print a badge and get it to the person. Think about that whole process all the way through. Think about the environment in the space. Is it obvious where they should go? Is it obvious what the steps are? Be helpful, welcome people, and give them a lot of options to keep things flowing. We've talked about check-in choices a little bit as we go through. We've mentioned kiosk and others. Pick the ones that are appropriate. For people who are absolutely new, the best and easiest thing for them is a person, someone who can greet them and just help them through that process, especially if they're lost or stressed. That's where they're going to want to go, and that's where they're going to naturally flow to. Make it obvious where that is. For people who come back a lot and areas of the hospital where you may have people who return again and again. Any place with sports medicine for the athletes that keep coming back with yet another injury, like Brent, or those types of places, kiosk is a great thing to mix in. It's not for the first timer; it's for the person who comes back a lot who says, "I want to save time." They're going to go get in that kiosk line. Um, think about things like how could they do this earlier? Maybe they check in at home and use a QR code that they can use to identify at the desk. There are some people who love to do that. They love to be prepared, but obviously, again, that won't apply everywhere. They're probably not going to plan their emergency the night before and go ahead and check in. So make sure you have several options that are there for people and guide them towards the simplest one. Think about that person who's never been there before. Um,
So
I
what I'm
think
hearing,
some other, sorry, I was going to say that I think I have a couple of other tips. And first, also, just keep your asks to a minimum information that you need in order to have them process. Don't ask for information that's unnecessary. Keep it fast. And then lastly, when you are sharing information with them, just share the information they need at that point, at that time. If if you can ask them what they're lost, are they lost? What were they looking for? You can start to learn where they are in their mindset, and that's the time they'll absorb the next step. So sorry about that, Brett.
no, but you actually answered what I was going to ask, which is what I'm hearing you say is reduce friction, make this as seamless as possible to help. And by reducing friction, you're reducing stress, and reducing stress, you're increasing outcomes. And so by only collecting pertinent information and giving them the basic of what they need, you're not overwhelming them with too much information, which can be equally as stressful. So you hit the nail on the head. You didn't need me. I could have stayed quiet.
All right. How about you then take the next one?
Yeah, I'll talk about watch list a little bit. So, watch lists are a really interesting way to think about it. You hear watch list, you think about maybe somebody that, it's an internal list that you've had problems with this person before. Maybe they were violent with a staff member, or, they are just a known, criminal, or maybe a known gang member or something that you're going to have some different security protocols for. One of the things that we don't ever like to think about, but we have to think about is sex offender watch list. How do you ensure the people that are in your hospital, the most vulnerable populations, are protected? And should you, and how and what should you do with people if they show up on these watch lists, and how should you handle them? It's a complicated situation that we could probably spend a whole nother podcast talking about. But watch lists don't have to only be negative. I think it's something to think about. One of the more forward-thinking hospitals that we work with was looking for ways that they could recognize their board members or the mayor or different VIPs when they walked in the door. I mean, if somebody has donated enough money to your hospital to have a wing named after them, you should probably have their picture at the front door, or another way to recognize who they are. So watch lists, they don't have to be negative. They certainly can be positive as well, but it gives you the ability to know how to handle them. So when that board member walks in, you know to call, the executive admin, or if the mayor walks in, maybe you call the PR team so they can come down and give the mayor a tour or whatever it is that the mayor is there for. to ensure that you're getting the support you need internally and externally with your organization. And really, ultimately, those two things together kind of take us to our next point. Don, I'll let you talk a little bit about layered security.
All right, thank you. Um, so layered security is really bringing this in appropriately with everything else. Kind of building from where Brent was just talking about watch lists and various options there. What are the right things to check at your location? I mentioned earlier weapons detection. I'm seeing people now starting to link weapons detection and spend more time on that process and link that to the visitor process. We're seeing people tie these systems together in different ways of, for instance, tying into the patient record system and using the patient records to pre-create visitors so we know who's expected today and we can see people who have appointments in the hospital already in the system, both to create a better sense of who's meant to be here and who's coming in, but also because it'll help increase process flow. Um, but I also like to look at this and look at a different aspect of layered security and take you back to where I started again when we were talking about stress and we were talking about lowering stress, which is to think about the patient experience and the visitor experience as a layer of security. Anytime you're working on a process flow and an experience like this, if you think about the people and you do reduce the stress level, you're going to improve security outcomes as a result. So look for places where people are slowed down. Look for places where people are lost. Look for places where people are delayed between, parking their car and getting to that patient that they're there to visit. And those are places where you can improve security outcomes by making it easier. And so think about that experience, the user experience, the patient experience, as a thing that actually makes us all safer. And it really is something that if you focus on all of these aspects, make sure people know where to go, make sure they understand the signage, make sure that as part of check-in, they're given that the check-in drives two directions of where do they go next, what to expect. All of that lowers stress, all of that reduces workforce violence, all of that pulls people back to a simpler system and an easier system, and lets them move through quickly without that kind of negative impact that we could otherwise build.
Well, it's like you said in our conversation the other day. It's you're hosting a bunch of friends for dinner and it's cold and rainy outside. You don't want them waiting in a line to get in the front door. You want to help
Absolutely.
them move through in a quick manner so that you can get in and do this. I mean, I realize dinner party and a hospital are a little different, but the idea is the same there. I think we should maybe look towards wrapping up. We're getting near time, so maybe offer a few takeaways and then answer some questions that work for you.
Sounds great.
All right. For me, I think the biggest key takeaway that Don and I hope you get out of this is put people at the forefront of your security. Make sure that you are looking at the impact, not only the people that are visiting your hospital, but on your staff, and making sure that the experience for everybody is great. If experience didn't matter, hospitals would still be cinder block buildings that are lit with fluorescent lights, but that's not the world we live in. I promise to give you a phone number today. That's my cell phone number. You're welcome to call me or text me. I'm happy to do a walkthrough if I can get to your town. If I can, I'm happy to FaceTime you or whatever makes sense to offer some insight, whether you're working with HID or somebody else. This is a initiative that I'm passionate about, and I want to make sure that you get it. And ultimately, we hope that whoever you work with to solve this problem, make sure that they're helping you. If they're creating more problems than they are solutions, find a new partner. But really, I wanted to thank you for listening to us ramble on today. Don and I can talk for hours. For us to keep it to a mere 45 minutes today is kind of a small miracle for those of you that know us. But would love to answer some questions at this point. So, Daniel, is there what's come in? What can we answer?
You got it. Well, first off, thank you, Don and Brent, for a wonderful discussion today. And as I mentioned, we will now begin today's Q&A. So, audience members, please feel free to submit any questions you have via that Q&A box there on your screen. And we'll go ahead and get started with the first question. This attendee wants to know, what's the typical timeline for putting in patient visitor management in a hospital with 200 beds? And a follow up to that, how do you decide where to start when resources are limited? I'm sure it's a question a lot of folks are facing. So, either one of you want to take a first stab at that?
Yeah, Don, I'll take first stab and let you jump in. Uh,
Okay.
yeah, 200 beds, pretty average size hospital. So for timeline, I'm guessing they're asking like the installation time. Is that how you read that, Daniel? Sorry, broke up a little bit on my side.
Yeah, for putting in patient visitor management. So, probably installation time. Yeah.
Yeah, so I think for to do this, obviously the walkthroughs and the pre-planning are paramount. If you put the effort on the front side and we come out, we do the visits, we look at this, we talk through the overarching problems together. The research will take a couple of months, but ultimately, once we decide to move forward with the project, we can have a system live in under 90 days. The complexity of the system is going to impact that, but I think looking at this, the installation time is not going to be detrimental. It is something that we should be looking at for this. Don, do you want to add to that, or you agree, or feel differently?
Yeah, and like under 90 days, I think you could be under 1 day to set up a system. The key with that is setting up the right system, make sure you're thinking through the details. Setting up a piece of software isn't really the goal, right? I think we made that apparent over the last 45 minutes. And I think you asked also where to start. For me, start small, pick small goals, and then improve on the system and add to the system as you go, and check in with people to how it's working. I've seen some people who start with the goal of let's just get badges on people in the hospital, tying into other systems like records management and things like that. They can bring those down the road. Or start with a single location, start in the lobby, figure out these satellite areas and other doors later. And then, like I said, phase things in. So if you can pick a couple of the easier goals, it really does help you build momentum.
Yeah, I second that, Don. I think a phased approach is what we are always recommending today. Let's look at the problem, collaboratively and give you a holistic dream state, and then let's break it down into manageable chunks and let's get wins. If you have a project that somebody tells you is going to take 15 months, please rethink the project. Start over, break it down into pieces where you can make the wins, make the adjustments as you go. So I couldn't echo what you said enough. What else you got, Daniel?
Yeah, great guidelines there. Thank you both. This next attendee wants to know how to get clinical staff to follow visitor policies. They're already so busy. Again, I'm not sure. Might take a little bit of convincing for the clinical staff. So, how do you go about that?
Yeah, change is hard. No doubt about it. But I think, understanding the benefits and really over communicating the benefits to the clinical staff. Is it a new system? Yeah. Is it different? Yeah. Does change, challenging sometimes? Absolutely. But I think you take the flip side of it and help them see the proof is in the pudding. When they recognize that their job is getting a little bit easier every day and you start to time these things. One of my favorite exercises to do is we look at incidents over a finite period of time before the system and after the system. We can say there's been a XYZ percentage reduction in incidents. I look at check-in times before and after the system has been live for 90 days. These are some things that I've done successfully. Don, what are some of the things that you've seen implemented to get the staff on board?
I think training, making them more familiar, like, sometimes that's just fine. Sometimes that's just look over their shoulder and make sure they know how this impacts them and what it's for. Even if they're not having to use the system, train them in what to expect from the system. Like, what does the badge mean? Where does somebody go to get the badge? Make sure they're familiar. And then maybe like the biggest piece though is way up front. Get members of the staff from as many parts of the organization involved as you can. Get those committees that this can help and this can impact. Give them a chance to have a voice about this, and that will help make sure it's responding to their needs, and that early on starts to break down some of those barriers. When you're building this and thinking about them and talking to them, a lot of that resistance to change goes away.
That's a really interesting point, Don. Thinking back, I've talked about the tour I did today a couple of times already, but one of the things that they did that I thought was really interesting is there were stakeholders from 5 different departments that showed up today. And
That's
there was
that's great to
one,
hear. Yeah.
it was amazing. There was one common thread of a problem. And this particular problem affected all 5 of these departments differently. And so all five of them had their idea of what they should do to solve this problem. And it only solved their needs. And whenever we were able to take a step back and look at it holistically from a 100,000-foot overview and walk them through how these small tweaks to the process and what we were looking at impacted all of them, we really got the buy-in we were looking for. And so it was five directors today. Our next group is going to be five VPs. I mean, and obviously they all thought it was valuable enough to bring their bosses in. So I can't echo what you said enough. What else you got, Daniel?
Yeah, thank you both. And thank you to the attendees for submitting these questions. We got a couple more here for you. This attendee wants to know, when you talk about incident reduction, what does that actually mean financially and operationally across the hospital? They added beyond the obvious, fewer violent events. What are the impacts we should be quantifying for our CFO and board? So kind of touching on metrics here you see tied to incident reductions.
That's a good one. Um,
Yeah, do you
Go
want me
ahead.
to jump in?
Yeah,
Okay.
take first crack.
Sure. Let me look at that. So we'll see people look at a few things. Some people are polling patient satisfaction. I've seen other people that they're tracking at the exit how many people are coming through that have the wristband or the badge or lanyard or whatever it is that's being given out to visitors, and you start to track, sort of percentage of people over a time frame that are following the process versus not, and see that it's start to see early signs that you're getting uptake. Look at staff and try to measure whether or not they are seeing an impact and a change in that. If you're not, are we making this simple enough? Even measuring things like time through the lobby, time spent in line. You can snapshot that really quickly with things like try to capture the line length at specific times during the day. Do they get a line? Do they get more than one person needing to check in and trying to gauge that depth, or measure the time to check in a person? Though some of those aren't core indicators. They're just good things that tell you that you're making progress across that.
Yeah, and I mean, I think to add to that, I think you can also, over a longer time horizon, look at your staff retention. And we talked about the cost to replace a nurse. That's an easy one. We addressed, about 20 minutes back. But with the cost it is to replace and retrain staff, you're going to see the ancillary benefits of doing something like this are really far beyond and a little harder to quantify at times. But we've seen things like a positive impact on patient outcomes and patient scores because you have a well-trained, well-oiled machine taking care of your people. Your reputation, as Don alluded to, and the more high quality of an experience you can offer, the better the taste is. So, what else we got?
The other thing, yeah, I was going
Okay.
to say the other thing we find that when we're polling this is, don't ask them about the system. They don't know what a visitor system is. Ask them about their situation. Ask them about, arriving at the hospital, or, was it easy to figure out where to go today? Ask them more general questions and not too specific, as you are trying to gauge, were they happy with the situation? Because again, the satisfaction or lack of dissatisfaction with the arrival process does help lower those stress levels.
Perfect. Looks like we got time for just about two more questions here. This next one's pretty straightforward. This attendee says, we use Epic. How does visitor management integrate to Epic?
Oh, that one's easy, Don. I'll take that one.
All right.
We are listening post for Epic. So Epic and any of your other EMRs use HL7 as a communication feed. We listen to that. We tie directly into it. So that is perhaps one of the easiest integrations that we have. Did I miss anything?
No, I think that's good.
Short and simple. Awesome. And we have time for just one more question here. This attendee wants to know, if visitor management is new, do we need to rip and replace anything, or can it layer on top? So kind of the integration piece, but how does it relate to stuff they might already have in place? Do you need to replace everything? Can it work together? What do you think?
No, I think it's designed. It's designed to work and integrate with. I mean, that's the beauty of HID Safe, right? And any high quality system should be designed to integrate with the existing systems in your hospital. It is not. You need to rip out all of your technology and start over. It's designed to be. I know Don was talking about a different thing when he said layered security earlier, but it's designed to be one of the layers of security. So it is designed to work with the existing items and supplement them. And there are times it may replace things, but largely speaking, no need to rip and replace.
Yeah, same answer. Like you're going to link into weapons detection, you're going to link into access control, you're going to link into the patient record system, like Brent was just talking about with the last answer. You would never really look at that to replace what you have, but you have to work with it. It may be part of a program where you're updating things. That's great, but if you have systems in place, you really want to work with what's there. Not forced replacement of things.
Terrific. That is all the time we have for today. So thank you, Don, and thank you, Brent, for an excellent presentation today. We also want to thank HID Global for sponsoring today's webinar. Thank you for joining us today, and we hope you have a wonderful rest of your day.